Well, greetings everyone, and welcome to the EKG case for the week of March 24th, 2014. Before we get started with the quick case for this week, I just wanted to touch base with you all about a new EKG training program that we have put together. You know, over the past couple of years, this EKG video series has, I think, been really helpful for me and hopefully for a lot of other people. And I've gotten a lot of really excellent feedback from a lot of folks, but a lot of people have also asked about a couple of other things. They've been asking about whether there's a possibility of getting CME for doing this, and I've held out against CME because that would really require some type of fee, and I've wanted to keep this EKG video series open access and free for everybody, and I also don't want to have a program where I'm using other people's EKGs to charge money for something. So I haven't done that thus far. People have also been asking about whether there's a more formal or programmed approach to EKG teaching that we can do rather than the assortment or potpourri of random EKGs from week to week. And I kind of like the potpourri approach because that's the way we practice emergency medicine. We don't see a series of patients with the same disorder. We see just random things, and that's what this EKG video series is supposed to represent. However, we've really tried to focus on what people are asking for, and with that in mind, EMED Home, which is a website on which I do a monthly podcast called EMcast, and I've worked with them for a number of years. What they have done is they've actually helped me create an advanced EKG workshop, which is maybe a bit more than a workshop because, well, it's online, so it's not actually interactive as much as I would like. But it's about 7 to 8 hours of videotaped EKG lectures that I do, and there's about 10 CME credits that you can get for it. And this is a more programmed, formal approach to EKG training. It is intended for people that already know the basics and are at least at the intermediate level, want to take their skills to a more advanced level. We'll focus on acute coronary syndrome and a lot of the mimics, as well as a lot of the subtleties, and bradycardias, tachycardias, a special section on wide complex tachycardias, including some of the mimics of VTach, deadly causes of syncope, and the real focus in this workshop is pearls, pitfalls, and screw-ups, a lot of which belong to me, a lot of which are my own screw-ups that I've learned from over the past 15 to 20 years or so. If you're interested in something like that, you can check out this course. It's online at EMED Home, www.emedhome.com, and sign up. You will get a copy of the DVD as well as online access to the full course. And we've done this once before, several years ago, got a lot of great feedback, and so this is a step beyond that. So hopefully a lot of people will check that out and get some really good, useful training from that particular program. Okay, on to this week's case. Speaking of syncope, this was a 12-year-old male that presented to the emergency department with frequent episodes of near syncope, or LH's lightheadedness. And so, we're not going to go into detail with regards to pediatric EKGs. We've talked a little bit about that before. I will mention that it is very common to have relatively tall R waves in a pediatric EKG in leads V1 and V2. Well, I'm having a little problem here. In leads V1, V2, and in V3 as well. And oftentimes in those leads you have inverted T waves. But what is hopefully noticeable to you, take a look at this and see if you can figure out the diagnosis. But there's something that's somewhat notable about this 12-year-old male's 12-lead EKG. First of all, there's fairly high voltage in a lot of leads, which may or may not be common in young, healthy men. But the other notable finding here is that there's very deep, narrow Q waves in a bunch of the leads, especially the lateral leads and some of the inferior leads as well. They're very deep, they're very narrow. Those are not infarction Q waves. Don't make the mistake of calling this old inferior and lateral infarction, right? These are too narrow. Infarction Q waves should be at least 1 box wide or 40 milliseconds wide. These are too narrow. When this is something that we've talked about before on the podcast, although it wasn't a 12-year-old, it was a young male in the previous video case that we did. In this particular case, this is the most common cause of sudden cardiac death in young, otherwise healthy males. This is hypertrophic cardiomyopathy. This is a must-know EKG for everybody out there who takes care of young people. And it doesn't matter whether we're talking about kids or adolescents or young men. Remember, the average age of diagnosis of hypertrophic cardiomyopathy is actually somewhere between 30 to 40 years old. It's not always adolescence. It's not always that college-age basketball player, but young men. It's almost always in men. And we'll skip to the take-home points here. What do you need to know about hypertrophic cardiomyopathy? It is usually exertional lightheadedness, exertional near syncope, or exertional syncope, but it doesn't have to be. Sometimes it can be even at rest. So don't ever rule this out just because the patient was at rest when they had their syncope. Right? It is much more common in men. I've never seen or heard of a case in women, although I'm sure it can happen, but it's something you've definitely got to consider in men. And the two things, there's a whole bunch of nonspecific EKG abnormalities that we can go into. I'm not going to, though. I want you to remember two very simple things. Number one, high voltage. In other words, large QRS complexes. All right? So big QRS complexes plus deep, narrow Q waves. Typically in the lateral leads, that's probably the most common place, but in this case you see them in the inferior leads as well. Deep, narrow, dagger-like Q waves anywhere on that 12-lead EKG in a handful of leads in the presence of high voltage in a male who comes in after syncope, near syncope, episodes of lightheadedness. That patient has hypertrophic cardiomyopathy until proven otherwise. And how do you make the definitive diagnosis? Very simple. You simply send them for a Doppler echo. And if that Doppler echo is positive, you know what? You just saved a life simply by knowing how to read a 12-lead EKG. All right. So this is a deadly diagnosis that can often be made or at least suspected in the emergency department. It's one of the can't miss causes of syncope or near syncope. When you have the syncope, near syncope patient in men, especially young men or adolescents, look for the high voltage and deep narrow Qs. If you see it, send that patient for a Doppler echo. You just might save a life. So I hope that was helpful. And also don't forget, check out that website at www.emedhome.com. Check out that advanced EKG course. Hopefully it will meet the needs of a lot of people who've been emailing me about a more programmed and thorough course on ACS, syncope, and dysrhythmias. All right. Hope that was helpful, and I will talk to all of you next week. Bye for now.
Okay, so this video is going to cover as many different shoulder dislocation reduction techniques as possible here. Okay, and so let's go for it.
So you can have an assistant for doing a prone technique for scapular manipulation. You can have an assistant just apply gentle anterior traction with them in the prone position. Again, same thing. You're going to come in and you get your thumb into position on the acromion and on the scapular wing, and you're going to rotate with the scapular wing going medially.
Okay.
So with the Spazzer technique, you're going to have them lay flat on their back. You're going to take them into vertical traction or anterior traction to the body, and you're going to do external rotation. So you're going to basically externally rotate the arm or supinate the hand, and you're going to continue that traction. You can also put a little bit of pressure on the chest, but you're unable to do scapular manipulation with that technique. This one I'm not as familiar with. You said you've done this in the past.
This is my go-to.
Okay, so again, they're in that same position, holding themselves at not full internal rotation. They're going to have their arm in this position. So the technique that's in the books is keeping the elbow adducted. You're going to allow it to externally rotate. You're supporting the arm, and that's to give them the sense that they're not just going to flop right out. It helps them relax. And you're just going to bring it out into external rotation, and this should reduce the shoulder.
I find my own experience, you have to almost do exaggerated external rotation, and then sometimes I don't even feel it going in. I don't feel it pop, but then when I bring it back, then
They're able to go all the way against the belly.
it goes all the way back down.
Now
So-
you had talked also about padding on the inside to help
Right.
with a little bit of lateral distraction.
Right,
So you pad on the inside, a little lateral distraction, same rotation.
right.
Now
And
the-
it's not uncommon for me to go ahead and put in 20 cc's of lidocaine into the joint in addition prior to this, and give it a few minutes for it to be absorbed
Okay.
for pain control.
So with the Milch technique, again, we're starting with the external rotation. We take them out to full external rotation. We don't get any reduction. From there, I'm not even sure how to do that, to be honest. From there, you're going to take them into full adduction, keeping them externally rotated.
Abduction.
Yeah, abduction. And you're going to take them into overhead extension, and you're going to apply gentle traction on the humerus with direct pressure over the humeral head. All right, so lay down flat.
Okay.
So with counter traction, so you're going to come up high in the shoulder, and it's just like it sounds. So he's going to be pulling traction going in direction against my traction. I'll be basically, you're going to keep her from moving,
Okay.
and I'm just going to lean back. And so all I'm doing, the key to this is gentle traction. Now, one thing you will see a lot of people, and I've seen people do this, is they'll start trying to reef on it because this is kind of an aggressive approach in general. All it is gentle traction, because what you want to overcome are the four muscles that are in the rotator cuff. And if you just keep that constant tension, they're eventually going to relax on their own. So it's not the amount of force, it's the gradual traction that's applied.
Okay.
So this is the Ferry's technique for anterior shoulder dislocation reduction. So you're going to have the patient lay with their arm completely to their side, and again, they're going to want to try and keep it preferentially up, but you just kind of gradually coax them into this position right here. You're going to apply distal traction. You're going to start manipulating the shoulder, coming into abduction, going up and down in a 10-degree arc. That up and down motion is intended to relax the rotator cuff muscles. Now, if you don't have an obvious reduction of the joint at 90 degrees, you okay? If you don't have an obvious reduction at 90 degrees, you can, at that point, externally rotate the arm and continue, and that should reduce the shoulder. The Cunningham technique for reducing the shoulder. So helps get down in line with the patient. Have the patient go ahead and rest their palm, grab your shoulder. Now again, getting them into this position, not getting my face in there.
Nope.
Getting them into this position is key because they're going to be really tense about it. So you're going to rest your arm in the crease of their elbow, and they're going to hold on, and that's going to create a little bit of gentle distal traction. And you're just going to massage the bicep.
Okay.
All right. Now you want.
They also straighten up their
I was
shoulders.
getting there, sir.
Okay.
I was getting there. You can just hop in. Am I narrating this or are you? Anyway, they're going to sit upright and they're going to take their shoulder blades back and keep their back.
Well, let's
as
set her
straight
up
as-
right then. All right.
All right, so at this point, I'm going to just be massaging. She's going to try and keep her posture as in line as possible, which helps keep the scapula in advantageous position for reduction. And you just want to make sure that you're rubbing on the areas involving the rotator cuff, so supraspinatus and infraspinatus regions, and a little bit on the anterior shoulder, and they should reduce.
Okay, so the biceps, deltoid, and all that stuff gets massaged.
Yes, sir.
Got it.
So Stimson technique for anterior shoulder dislocation reduction. You have the patient in the prone position with their arm extended in front of them. Hardest part is to get them into this position in a relaxed fashion to where they don't tense up. You need to go ahead and place a harness on. This one has an inflatable cuff to help secure it to the forearm. Just go ahead and verify that they actually have a distal pulse before you go apply the bag. All you're going to do is bag about 10 to 15 pounds traction, or 10 to 15 pound weight bag, and it's going to apply gentle traction. Key thing, you want to make sure that the bag actually hangs off the floor and you have enough distance for it to go. Now a variant on this would be again, you could do the prone technique of scapular manipulation along with the Stimson technique, which would just then make it the prone technique again. So identify the acromion, scapular wing, translate the inferior scapular wing medially, and you should get a reduction. Go ahead and lay flat. So the counter traction for inferior dislocation. So the patient's going to generally present with their arm in the fully adducted, or abducted position, arm above their head, inability to mobilize the joint. So you're going to drop the sheet, lift your head a bit, and drop the sheet under their body. Your assistant's going to go ahead and do counter traction. What you're going to do is control the arm. You distract the humerus, pulling it back into alignment and in line with the glenoid, and it should reduce. So this is a reduction of a posterior dislocation. Oftentimes patients will present with their belly or their hand flat against their belly. So essentially it's going to start a lot like traction counter traction with the anterior technique, except for in this instance we will stay anterior. We're going to go ahead with external rotation. So we're going to externally rotate and draw them anteriorly, continuing the external rotation. Another method you can add to it with the external rotation, grab the humeral head and attempt to guide it anteriorly along with that traction. You can also place a sheet up in the axe pocket to help draw if you're unable to get the angle on it to apply the force.